So the next part is actually very exciting because we're going to talk about bispecifics in myeloma, and that's a new avenue that has actually opened recently in the treatment of multiple myeloma. So far, we have now drugs that are part of these bispecifics that are approved in the US and also in Europe, and some of those also in Canada. I changed a little bit the name of the presentation just to call it T-cell directing therapies in multiple myeloma, because the BiTE expression is something that was used initially by Amgen when these BiTEs were done against ALL. So this is more a T-cell directing therapy, and I'm going to present some variations of that, the same conflicts of interest as presented in the slide before. This is just the intro that we use for myeloma. The bispecifics are actually used in a population of myeloma patients that is an unmet need, and this is a group of patients that we call triple-class refractory patients. These are the patients where the median time to development of triple-class refractory is actually shorter, around 3 years from the diagnosis of multiple myeloma. And these days we can say that patients with myeloma live around 8 to 10 years, and in the low-risk group perhaps more than 10 years. But the triple-class refractory, the median progression-free survival is very short, only 4 months, and the overall survival is in the range of 1 year from the time that they achieve this status of triple-class refractory. So the BCMA-targeted immunotherapies in multiple myeloma appear in different ways. It can be the antibody-drug conjugate, and the example of that is belantamab. Another one is the CAR-T-directed therapy, which I know that there might be a presentation tomorrow, virtual. And the other one is the use of these bispecifics. And one of those is teclistamab, but there are other antibodies. There are antibodies that are naked, and there are antibodies that have other markers that are not only BCMA, and there are actually treatments where we can actually combine the use of some of these multiple targets. So we're going to be discussing about these bispecifics, but when we talk about the antibodies, they can be antibodies that they have nothing attached. We call it naked antibodies. They're antibodies that can have either a toxin or a radioactive isotope that is attached to the protein conjugate. And there are antibodies that do have the properties of being engineered so that one of those ends binds into the myeloma cells, and we choose the target, whether it's BCMA or other targets that are presented, and the other ends binds to the T cells. And there is a part of these antibodies where they can be actually T-cell stimulation with the hope of keeping the T cells active and preventing the myeloma cells from coming back for longer. There are patients that nowadays can be treated with CAR-T, especially in the US, it's available. There are some issues with regard to CAR-T, but we're going to defer the discussions about that for the presentation tomorrow. But it's just to say that patients with CAR-T still relapse, that the CAR-T doesn't seem to be curing myeloma. Obviously, this has been used in patients that are very refractory, whether it's triple-class refractory or penta-refractory, but you can see from the KarMMa-3 study where the patients still relapse, even what is better than the standard of care. And the hope is that if we use it earlier, perhaps the benefit will be more meaningful, and that is actually manifested, for instance, in the CARTITUDE-4 study that you guys very likely will be discussing tomorrow. But because the CAR-Ts still don't keep the myeloma cure, then the myeloma will come back. And that's when the bispecifics might be still needed. Obviously, the bispecifics that we're going to talk about, there are some that are based on BCMA, so if patients receive a CAR-T first, then bispecifics might not necessarily be that active when the same, that is the theory, that it might not be perhaps that active when the BCMA is used, and there are some mixing data in that regard. But we're going to talk about these antibodies first from the beginning, and the first one that I want to mention is the teclistamab, which is a combination of a BCMA and a CD3 bispecific antibody. And this is one of the initial studies where the patients with relapsed and refractory multiple myeloma were included, and this is kind of the use of the IV teclistamab and the subcutaneous form of the teclistamab at different dosages. And this is on the part 1 based on the recommended phase 2 regimen dose with the idea of treating the myeloma. And this included patients that were treated, as you can see right here, with a median of 6 and 5 at the recommended dose prior lines of therapy. So patients that were very, very heavily pretreated, and around 20% of those patients actually manifested with extramedullary disease. So this is the report from the phase 1 first-in-human study of teclistamab, showing that the hematological toxicities are suspected now with more use of these drugs. We expect to see more cytopenias. but the presence of CRS and ICANS was something that was seen in the CAR-Ts, and that's something that we also start seeing in patients with the use of bispecifics. What is the benefit of using these bispecifics is they don't have to be manufactured. We don't have to use bridging therapies. Patients actually get it off the shelf and they can get it right away. But something that started emerging with this is the presence of new infections. So around 20% of patients actually presented with grade 3 or 4 infections across all subcutaneous doses, and 23 had grade 3, 4 infections at the recommended phase 2 regimen dose. There was neurotoxicity in a very small group of patients, so that's not something that is necessarily that concerning. But we started seeing novel side effects that we were not used to see with the previous drugs that we have for myeloma. This is a report from the Majestic-1 study, which is a phase 1/2 study looking at teclistamab for relapsed refractory after 3 or more prior lines of therapy, and you can see something that is very unprecedented in this particular group of patients, seeing 63% of responses. If you think of daratumumab, when it was approved, the overall response rate at that time was 29% of the initial study. So having double type of response in patients that were even exposed to daratumumab suggests how these drugs are very beneficial and deep in getting responses. So when you look at the responses, you can see not only that the responses are 60%, but also you can even see MRD negativity in important group of patients. The median duration of the response is around 18 months, and the median PFS is 11.3 months, and overall survival of 18.3 months. And we were talking about patients that had a median PFS of 4 months and a median overall survival of no more than 1 year. So having these results is very promising. When we look at this study, the median follow-up was around 14 months, but responses seem to happen right away. Within the first month, you can see most of the responses, and around 1/4 of patients might get into the level of MRD negativity, and in particular, 46% of patients with complete responses might have actually MRD negativity. This is a study, a phase 1b study, looking at the subcutaneous teclistamab in combination with daratumumab, and you can see that this is a very heavily pretreated population, and some people were exposed to these triplet-class refractory drugs and even antibodies without necessarily being refractory. Only 60% were refractory to anti-CD38s in the past. You can see the same. The toxicity, hematological speaking, is similar to what was presented in the phase 1. You start seeing CRS in around 65% of patients, but you start also looking at infections in a more prevalent way. This is a study where teclistamab is compared from the studies on the clinical trials with the standard of care. This is an historical comparison, and as I mentioned to you, with the standard treatments that we have available for this population, you get anywhere between 25 to 30% of responses. So having the double with this bispecific is very, very promising when we talk about new drugs in this unmet need population. And then it comes another antibody that targets the same BCMA, but it actually comes from Pfizer, and this is a bispecific antibody targeting BCMA and C3 called elranatamab. And you can see the same 64% responses. You see levels of MRD negativity similar to what you've seen in teclistamab, and you can see the 12-month event-free probability after response of 60% of patients. And even patients with exposure to BCMA seem to respond. So it seems that there are different factors that might preclude some predictability of response, and there is some interesting data from our group in Calgary that actually look at some analysis, mutation analysis, and the presence of different subcell populations that potentially can predict the responses to these bispecifics. This is a phase 2 study of elranatamab, and essentially patients were heavily pretreated. You can see that around 30% of patients had actually extramedullary disease. All those patients, or most of them, were triple-class refractory, 96%, and pentadrug refractory, 42% of patients, with 96% of patients being refractory to the last line of therapy. And you can see the same, 61% of responses occurring during the first month. And you see also the same level of hematological toxicities, were very mild, just grade 1 and grade 2 CRS and ICANS, but the presence of infections was also important. There are other antibodies that are also based on BCMAs, and this is one from AbbVie called ABB383, and you can see the same depending on the dose that you see, the 40 and the 60 milligrams, and when you include all patients, between 58 56 to 61% of responses are seen in this group of patients in the 40 and the 60 milligram dose, and the median time to response is in less than 1 month, with a duration of response rate at 12 months of 79.9% in the 40 milligram dose and 68 on the 60 milligram dose, and the PFS expected at 12 months of 56 and 48% respectively. Same toxicities as presented from the other studies. There is another bispecific called linker MN1, and there is the data here from the phase 1, phase 2 study. This is by Regeneron and also targets a BCMA, and you can see that the responses, depending on the dose, go all the way down to 75%. So most of them are moving within the 60 to 70%, and that's very promising with this group of treatments. Thinking of a population that is very refractory and a population that has no more than 1 year survival expected with the standard of care treatments available until now. This is data from another antibody called alnuctamab, or CC93269, where it combines also a BCMA and CD3 strategy. And you can see responses are similar. 63% of these patients, based on the dose, less than 30 or more than 30, is around 65, between 53 and 65%, which is really, really promising. But there are other markers that we can target with these bispecifics, and one approach is targeting this marker that is expressed in most plasma cells and seems to be really, really interesting, and something that we can actually combine even with other biomarkers. I'm going to present some slides in the next few moments, but this is GPRC5D. And this bispecific antibody is also developed by Janssen. It's called talquetamab, and the study that I'm going to present here in the phase 1 is the Monumental 1, and you can see overall responses on the level of 73, 74% at 0.04 and 0.08 milligrams per kilogram. The median follow-up is still short, but you can see that the responses occur during the first month, and these responses seem to be very durable. The patients that do have better responses, the ones that achieve complete response, are the ones that seem to maintain the responses for longer. And the toxicities are similar to what you have with the previous bispecifics in terms of the hematological changes, but there are some other features that are appearing in terms of side effects, affecting the nails, affecting sometimes the taste of different food. And those seems to be new side effects that are more commonly seen with these bispecifics that we didn't have in the past. And there are some infections that we were not used to have with the previous treatments, and we're going to mention a little bit more about that. But there is another antibody that has been tested in myeloma. This is called cevostamab, that targets the FCH5 and the CD3. And this is another bispecific. As you can see right here, the overall responses can go all the way up to 56.7% with a higher dose, suggesting that you can actually target not only BCMA, but you can target other markers with responses that seem to be similar. This is a slide. As I said, I'm going to make available all these slides on my 2 presentations for any of you, so don't worry about remembering of this data, but it just to suggest that all these antibodies can be seen in the myeloma field, and now we have teclistamab, elranatamab, and talquetamab approved and hopefully available soon in countries like the US, Canada, and some European countries. And that's something that we might be facing, treating myeloma patients with these drugs and learning how to make them not only efficacious, as you can see that the efficacy is good, but to try to learn how to give and deliver these drugs in a way that is feasible. These patients get ramp up dose when they start on day 1, day 4, and day 7, and then they go home and they continue the treatment. But they have different infection patterns that we didn't have in the past, and we're going to talk about some recommendations. But this is an interesting study that was presented by Mariví Mateos in IHA this year, and it's actually called Redirect TT1 study, looking at the combination of 2 different markers that are targeted by these bispecifics. One is teclistamab that targets BCMA, the other one is talquetamab that targets the GRC5D. And the idea was to sequence these treatments every 2 weeks to see whether by combining bispecifics that target different markers could potentially make it even better. So this is a phase 1b study, and the design is done in dose expansions based on the different levels, based on the side effects. And what you can see is a very heavily pretreated population with extramedullary disease in 1/3 of those patients. Most of people with a median number of 4 prior lines in the different levels of assessment of the escalation doses. And most of the patients actually refractory to the prior therapy, and 80% of those actually being triplet class refractory. Hematological toxicity seems to be similar to the other bispecifics, but you start seeing a little bit more on the non-hematological toxicities. The CRS, similar to what you see with other bispecifics, around 70%, 76%, but you start seeing dysgeusia, you start seeing some skin toxicity, nail disorders that seems to be particular to the off-targets with the talquetamab, and those are the new side effects that seem to be more particular to this level of this type of mechanism of action by these drugs. So the other thing that can be a little bit more concerning is these infections, and some of these clinical trials were actually doing in patients that were very heavily pretreated, that they have immunoparesis, which is the decrease of the immunoglobulins that are not affected by myeloma. And then the questions of what can we do to improve perhaps the immune response. And one of the things that we're going to talk about is the recommendations or the prophylaxis for different infections. But you can see that the CRS is not something that is different from the use of one bispecific by itself. The responses seem to occur very fast. There are different treatments that we can use for this CRS that seems to be similar to the others, but you can see that most of the patients actually have CRS on the first cycles, and after that the CRS symptoms are less. But you still see a lot of infections that people might say, you know, we're living in the pandemic and COVID is there regardless of whether we use these treatments or not. The reality is that some people still die of these infections, whether it's COVID new, but also they develop infections in the lungs, they develop viral infections that we didn't see in the past. There are patients that we have seen in our clinics with adenovirus and other viruses that we're actually more used to seeing people treated with allogeneic transplants and not necessarily with the lenalidomide or bortezomib for the treatments that we normally use as standard of care for treatment in myeloma. So we have to learn how to prevent this, and there are a consensus that I'm going to review with you guys today, but essentially those are the things that we have to evaluate, especially when we're trying to move these bispecifics to earlier phases of the treatment of myeloma. But you see with this combination, the responses are very impressive, 86.6 with all those levels. And when teclistamab is used at 3 milligrams per kilogram every 2 weeks and talquetamab 0.0 milligrams per kilogram every 2 weeks, the responses are seen in 96.3% of patients. So very, very effective combination. The median follow-up is still short, 13.4 at all levels, and with a more matured dose escalation of only 8 months. But these responses are very impressive in a population of very heavily pretreated patients with extramedullary disease. And you can see that the responses are seen even in those patients with extramedullary myeloma, which represented around 1/3 of the patients treated right here. And this is an example. These are the slides provided by Mariví Mateos. And you can see a patient with a PET-CT showing multiple areas of involvement by myeloma, and after treatment, this is from October of 2021, and after treatment for a few months in January of 22, this PET-CT looks way better. So within a few months, you can see a real benefit with these treatments. And as I said, what we have to learn is how to use it. Now that we know that they're efficacious, is to use it and perhaps to prevent the possible complications, including these infections. And the conclusion from the study group is that the combination of different market-driven bispecifics is something that can be done, that the combination seems to be giving the same hematological side effects expected for the bispecifics. So the combination is efficacious, and so far the toxicity seems to be similar to what you expect with bispecific by itself. But the infection issue remains as an important one, and there is a consensus by this group of people that was just recently published in Lung Cancer Journal, where some recommendations were given. That is not really based on any clinical trials, on any randomized data. It's mainly a consensus based on the frequent toxicities that we have seen. And is recommended to use antiviral prophylaxis against HSV and varicella zoster in all patients. It's recommended to screen people with hepatitis B because of the risk of reactivation. IVIG is suggested to be given for patients with these treatments, and what we call immunoparesis, which is the decrease of the immunoglobulins that are not involved in myeloma, is something that we normally see in around 93% of people at the time of diagnosis. So the more treatments that they get, normally patients actually perpetuate this cycle. Sometimes it's really not mentioned as an important thing because most of the patients with myeloma do have an IgG kappa. So when you look at the immunoglobulin G, you will see that the immunoglobulin is always high. But if you do subtraction between the monoclonal protein and the total immunoglobulins, you will see that the immunoglobulin that is left out is always lower than what you might expect as normal. And that's why they suggest that even without clinical data and without targeting 0.4 or 0.5 at the level of immunoglobulins, patients that are going to be treated with bispecifics after the first month are to receive this. And there is also another factor that occur with these bispecifics that are made of IgG kappa protein. That's the marker that we're targeting from the BCMA perspective. So there is always recirculation of the immunoglobulin. So if you look at immunoglobulin G as a potential reflection of how low the immunoglobulins are, on the first month you will see that the immunoglobulin is recirculating and it might be actually higher than it is. It might be dysfunctional, it might be just the IgG that comes from the bispecific antibody as opposed to the normal IgG that might help you fight infections. And that's why the study, even without having all this consensus, even without having real data, suggests to give IVIG prophylaxis for everyone, because they are trying to protect as much as possible people. For grade 3 neutropenia, is recommended the use of GCSF. There is no prophylaxis that I recommend for aspergillus, but I recommend to use PJP prophylaxis for all patients. So there are other targets in myeloma that potentially have to do with genomic anomalies. This is the last one. And perhaps also with excess of protein production and immunosuppression to restore the anti-myeloma immunity. And that's things that we're hoping that will potentially help us to treat patients with bispecifics better. But the main thing is to learn how to deal with the toxicity. And with that, thank you for the invitation and the attention to these two presentations.
Thank you very much. Impressive talk, as usual.